In addition, important anesthesia topics, especially for the postgraduate students and practicing anesthesiologists, were also included.
The history of anesthesia is rich, varied, and full of sacrifice.
Program befitting the standards of the College of Anesthesiology. In addition, important anesthesia topics, especially for the postgraduate students and practicing anesthesiologists, were also included.
The history of anesthesia is rich, varied, and full of sacrifice. Program befitting the standards of the College of Anesthesiology.
My seniors, friends, and colleagues, good evening and namaskar. You all know we lost our patron, chief advisor, the founder and developer of Indian College of Anesthesiology, Dr. V.P. Kumara. Last Wednesday evening, while I was opening, I informed you all he is gravely sick and he left all of us in the early morning of Friday, 3rd February. The funeral was conducted on 4th February at Lodi Gardens, New Delhi. We are mourning. We will mourn till 15th of this month. And Shraddhanjali will be conducted by the family members of Dr. Kumara on 15th February in the afternoon at Satyasai Auditorium, Lodi Gardens, New Delhi. And we all pray for the settlement of the soul. And we believe the soul of Dr. Kumara will be listening us, and God Almighty will make comfortable and safe. Well, our session has to go on. And I request President Dr. Jayashi Sood open the webinar of the day. Thank you all.
Good evening, everybody. So to begin with, we will be dedicating this seminar to our respected late Dr. Kumara. This is the 134th seminar being held today. And you can see Sir being present in all our activities, whether it was the departments or the college. Dr. Kumara was always there. And these are some of his photographs, always so smartly dressed, impeccably, and always there with all of us in such a smiling and joyous way as we did so many celebrations. Today, the webinar, the next week's webinar is on scientific publications, what we need to know. It's a very important webinar that I'll request all the seniors and the juniors to attend like they do always. And today, of course, we have the anesthesia management of obesity, which is now we say it's not obesity, but globesity. And we have very good speakers and the moderators, Dr. Raghavendra Rao and Dr. Muralidhar Kanchi being the moderators, and the speakers, Dr. Niskarsh, Dr. Madhuri, Dr. Indrani, Rangalakshmi, and Dr. Rakesh. They are all very senior doctors and who are very well versed in this subject and are dealing with these patients day in and day out. So, to introduce Dr. Muralidhar Kanchi, who is the moderator of today, we all know him very well. He is our National Dean of the ICA, and he's the director at the Narayan Health City in Bangalore. Plus, he's also the professor and senior consultant, of course, in the anesthesia and critical care, and the principal Narayan Hridyalaya Institute. His main institute is, of course, Narayan Institute of Cardiac Sciences, Bangalore, and his area of expertise is cardiac anesthesia, teaching, training, and he does a whole lot of workshops and a fellowship also being conducted in his institute. He has several awards to his credit, the Rukmani Pandit Award, Professor of International Health, Course Director, of course, he is there, and he's also a PhD from Netherlands. So Dr. Muralidhar, I request you to start the webinar today. Thank you.
Thank you, Dr. Jayashree, for that kind introduction. I'm grateful for the opportunity provided to us to conduct this webinar. Obesity is a common problem and it is almost replacing malnutrition, undernutrition, and infectious diseases. And it is important because it's not only a cosmetic problem, but it is associated with several serious disorders such as cardiovascular disease, diabetes, hypertension, cancer, etc. And we do encounter these patients in our daily practice of anesthesia, and we have a very brilliant galaxy of faculty to deal with this subject. And it's my great pleasure to invite Dr. Niskarsh Gupta, the first speaker to speak on anesthetic concerns in obese patients. Niskarsh is from All India Institute in New Delhi, very well known for his academic acumen, and is an excellent coordinator and very good at his work. And it's my immense pleasure to introduce to you Dr. Niskarsh Gupta, Professor, All India Institute, New Delhi. Dr. Niskarsh will be talking about anesthetic concerns in obesity.
Good evening, everyone. Thank you, sir, for the kind introduction. And I thank ICA, Dr. Jayashree, and everybody in the ICA team for the opportunity. I'll try to sum up regarding the basic concerns with respect to anesthesia in patients who are obese and morbidly obese in this 15 minutes talk. I have nothing to disclose. So all of us know obesity is now a pandemic and it is second only to smoking as a preventable cause of death. And it is responsible for major morbidity and mortality, which is resulting in major healthcare spending worldwide. So by definition, it is as a disease because it is a physiological dysfunction of human organism with environmental, genetic, and endocrine etiologies. I'll be coming to it further in the next slide. So broadly, we classify obesity based on BMI. So up to 25 is normal, 25 to 29.9 is overweight, and we classify as class 1, class 2, class 3 obesity depending on the gradation of the BMI. And having a BMI more than 50 is a super obese. So these are the various factors which may eventually lead to obesity. So we have biological factors. So you have some genetic predisposition to being obese. Then the environmental factors, availability of food, what are determinants of health and overall environment which is there, and socioeconomic status, and behavior and cultural factors, physical activity involved. So all this basically tends to have an influence, and the net balance of intake and expenditure determines the overall excess calories and eventual weight gain over a period. So a positive caloric balance is stored as fat in adipocytes as triglycerides, and it may initially increase in size up to a BMI of 40. Thereafter, there can be an increase in absolute number of adipocytes. The lipoprotein lipase regulates the storage of triglycerides, and abnormal activity of the abnormal fat may lead to metabolic disturbances. So environmental factors like stress, smoking, we know they will stimulate cortisol, and this will further stimulate deposition of abdominal fat. So now we have accept that waist to hip ratio of more than 1 in men and a 0.8 in women is a strong predictor independent of total body fat of morbidity and mortality associated with obesity. Now coming to the adipocytes, so these are the normal adipocytes, and gradually they will increase in size over a time. So in addition, there can be inflammation due to a lot of neurohormonal changes which are occurring, and which leads to increased lipolysis, insulin resistance, endothelial dysfunction, and eventually all these sum up and may lead to cardiovascular disease, diabetes, and malignancy. Moreover, these patients do have some psychological issues. They have eating disorders which are associated with depression and anxiety, and the drugs which we give to treat anxiety and depression, they may itself lead to weight gain. So various drugs like anticonvulsants, antidepressants, antihistaminics, steroids, oral contraceptives, oral hypoglycemics, these may lead to weight gain, and they may be one of the cause of obesity in the patient. Now coming to diseases associated with obesity. So broadly, it is a multisystemic disorder, and it involves everything from head to toe. Starting from brain, it may lead to mood disorders, social stigma. There can be chronic inflammation leading to altered immunity and increased risk of infection. These patients are exposed to a risk of chronic cardiovascular disease. The cardiac output is generally increased, and standard monitoring is less reliable, we know, and I'll be coming to it in later slides. In addition, there can be good respiratory morbidity also. So there's a reduced compliance, FRC, and there can be increased requirement of oxygen and increased CO2 production. Overall workup breathing is also high. The liver involvement is also there, and there can be non-alcoholic fatty liver disease, which we know liver is important for drug metabolism for anesthetists. So altered drug metabolism will be there, which will affect the recovery of the patient. Similarly, the kidneys are also involved, and there is an increased risk of acute kidney injury. In addition to this, the pharmacokinetics of the drug is changed, and the drug dosing also is very tricky, and we have to be careful. I'll be discussing it in subsequent slides. So coming to endocrine disorders, so it is known to cause metabolic syndrome, glucose intolerance, and type 2 diabetes mellitus, and endocrinopathies like Cushing's and hypothyroidism. The metabolic syndrome is a broad term which includes abdominal obesity, dyslipidemia, increased blood pressure, insulin resistance. It is a pro-inflammatory and pro-thrombotic state, and other issues like endothelial dysfunction, microalbuminemia, polycystic ovarian disease, hyperuricemia. So all these things also occur. So the clustering of group of defined metabolic and physical abnormalities is now put together to make a metabolic syndrome. So if we talk it objectively, so once we define it, so if we have a central obesity with waist circumference of 102 centimeters in men and 88 centimeters or more in women, along with any two of the following criteria being triglycerides, HDL, blood pressure, and fasting glucose more than 110, then we define the patient as having a metabolic syndrome. This becomes important because so there can be multiple comorbidities because of obesity in the patient, and this is one of the reasons for doing a surgery for weight reduction. Coming to cardiovascular disorders, patients who are severely obese tolerate exercise poorly. Mostly the cardiac output is achieved by increase in heart rate because stroke volume and ejection fraction are already to the brim and they cannot increase further. Moreover, changing the position from sitting to supine is associated with increased pulmonary capillary wedge pressure, mean pulmonary artery pressure, along with decrease in heart rate and SVR. So cardiac output increases by about 100 ml per minute per kg of adipose tissue weight gain. In addition, as we discussed, there is an increase in cytokines which may lead to damage to the arterial wall, and overall it may lead to eccentric and concentric LVH, predispose the patient to heart failure and pulmonary hypertension. A decrease of 1% of body weight, it tends to decrease systolic blood pressure by 1 millimeters and diastolic by 2 millimeters. So a poorly controlled hypertension is associated with labile blood pressure during general anesthesia, and as we know, labile blood pressure in turn is associated with increased cardiac, neurological and renal comorbidities. So we have to be very, very careful in handling these patients. Similarly, hypertension is 3 to 6 times more common in these patients. So it is multifactorial. So hyperinsulinemia leads to increased adrenal activity, increased aldosterone and increased blood pressure. In addition, it leads to increased absorption of sodium and salt, which increases volume in the intravascular space, which in turn increases the cardio output and eventually increased blood pressure. Also, there is a distribution of sodium potassium which is disturbed, and it affects the total peripheral resistance and increases the blood pressure. So this slide sums up the effect on the heart. So we have fat deposition in the myocardium. There is insulin resistance. In addition, which leads to increase in oxygen demand. There can be liver steatosis. All these things lead to altered metabolic profile, increased traditional cardiovascular disease risk factors like dyslipidemia occur. Then we have increased heart rate and cardiac conduction defect, which is altering the cardiac contractility. We may have autonomic dysfunction. Then there can be decreased peripheral resistance. Mechanical effects of fat on chest wall will lead to increased filling pressures in the ventricle and increased pulmonary artery pressure. In addition, patients do have pulmonary issues like obesity, hyperventilation syndrome or obstructive sleep apnea. All these things also increase the PA pressures. And kidneys are involved, leading to increased blood volume and angiotensin too. So overall, there is a relatively high volume status, and the heart is not geared up to withstand that and is prone to heart failure. Similarly, redundant tissue in the upper airway, thorax, abdomen is there, which will affect the lung volume, gas exchange, compliance, and work of breathing. Generally, it is a restrictive pattern of the lungs, and added weight impedes the motion of diaphragm in the supine position, and FRC, ERV, and TLC will decrease. Accumulation of fat in and around chest wall and abdomen will lead to increased pulmonary blood flow and decrease the lung compliance. And these changes are most evident in supine position, which is a common position for surgery in anesthesia. Then increased BMI leads to increased oxygen consumption and CO2 production. So to maintain a normocapnia, obese patients have to increase minute ventilation, and they do it by increasing the respiratory rate. So rapid shallow breathing is mostly common in these patients because this kind of pattern tends to utilize minimum energy. So this is the most important thing, effect on the respiratory system. So FRC declines exponentially with increasing BMI. And so what will happen is, so FRC decline leads to small airway closure, which may in turn lead to VQ mismatch, increased shunting and hypoxemia. More importantly, under anesthesia, these changes are exaggerated. So in a non-obese patient, the decrease is up to 20%, but in obese patient, the FRC decrease will be up to 50%, and there is a small airway closure is quite common. So we can see that before induction, the lungs are apparently normal, and after induction in obese patients, there can be an atelectasis in the basis, and these patients tend to have hypoxemia in the postoperative period as well. Another important thing in obese patients is obesity hyperventilation syndrome, the long-term consequences of obstructive sleep apnea, characterized by nocturnal episodes of central apnea due to desensitization of respiratory center to nocturnal hypercapnia. So it is important to know, because even light sedation in these patients, suppose we are doing outside OT procedures, may lead to complete airway collapse or respiratory arrest. Well, this is quite common. I'm sure everybody knows it. This is a stop bank questionnaire, which tends to ascertain the possibility of OSA. So we have history of snoring, tiredness, observed apnea, high blood pressure, BMI, age, neck circumference, and gender. We have to do yes and no in them, and every yes is a 1 point. Any score more than 5 is high risk, and 3 to 4 is an intermediate risk. This is quite commonly used and important to be used in these patients. Coming back to respiratory system, so as we discussed, it leads to decreased compliance, decreased overall drive, vacuum mismatch, and hyperventilation. So as anesthetist, why it is important to us? Because there is a potential difficult ventilation in laryngoscopy, though intubation may not be as challenging, provided you prepare for a difficult airway and do a ramp position. They are prone to hypoxia, so we have to do a good pre-oxygenation, and we have to give PEEP if needed, and extubation might be tricky in such patients. Similarly, GI disorders are quite common, starting from GI cancer, gastritis, esophagitis, and GERD, pancreatic cancer, pancreatitis, liver disease, specifically non-alcoholic fatty liver disease, gallstones, and inflammatory bowel disease. As anesthetist, it is important to resort to aspiration prophylaxis and a gastric volume assessment. Nowadays we have ultrasound, so that becomes an important tool in the preoperative period. Another important concern for anesthetists is increased risk of thrombosis because of chronic inflammation, impaired fibrinolysis, and immobility, heart failure, and venous stasis. So we have to be careful. We need to use multiple methods to prevent thrombosis in these patients if they are posted for surgery. So I'll skip this. The nervous system, we know that these patients may have autonomic dysfunction and peripheral neuropathy. So it is important for 2 counts. Firstly, pressure sores and nerve injuries are common, so we have to be really careful while we are positioning them. Secondly, any pre-existing dysfunction in the autonomic and peripheral system, nervous system, should be documented to prevent medical legal hassles. So now another important contention for anesthetists is how do we dose them? I'm sure other speakers will be going into details, so I'll just touch upon it. So there are a lot of factors which affect the pharmacokinetic of drugs, like volume of distribution, protein binding, drug metabolism, excretion. So at all levels, the drug metabolism is affected. So we have to be careful, and we have to give the drug as per the need. So we have an ideal body weight, we have adjusted body weight, and we have so we can calculate them. So ideal body weight is 50 kgs. So these are the formulas. I'll not go into details. So we have calculators as well. But it is important to know that all the induction agents, lignocaine, has to be given by adjusted body weight. And ideal body weight, we use opioids mostly, and some non-depolarizing muscle relaxant. Otherwise, we use total body weight. So we have to titrate the drugs to effect with incremental doses or incrementally adjusted infusion. So this is important. Even if we calculate with the help of a weight, we have to go slow and low in these patients. Another important thing which need to prepare as anesthetists, so we know the patients are obese, they have a large body habitus, so they have a good BMI. So we have to prepare the OT as per the need. So the positioning is important. So you need good tables, heavyweight capacity beds. Then we need mechanical transfer may be difficult, so we can have aides and enough people in the theater to help in transfer. Then we need extra long needles because of the fat, if you're putting a block in the preoperative period or during anesthesia. So you need the needle should be good, long enough for the block to be successful. And appropriate size NIBP cuff and other monitoring techniques should be there. Then coming to the problems in these patients, so we have already discussed. So we have obstructive sleep apnea, we have obesity, hyperventilation syndrome, respiratory disease, asthma, GRE, osteoarthritis, non-alcoholic steatohepatitis, renal disease, hypercoagulability, metabolic syndrome, diabetes, hypertension, and cardiovascular disease. So we have to be really careful. We should know all this possible system involvement in these patients, and we have to prepare them accordingly. Specifically for anesthetist, we have to be careful about the airway. We have to be careful about positioning and vascular access, possibility of hypoxemia during the surgery, possibility of a cardiac failure and CAD, and a decreased central respiratory drive, which may be difficult to handle in the postoperative period. So to summarize, comprehensive pre-anesthesia evaluation for comorbidities is very important in obese patients. We may need to do additional tests, specifically in patients with higher BMI, to rule out associated other factors which might be troubling us during the surgery and the post-op. We need to prepare also as per associated comorbidities, and additional logistic issues due to obesity may be there, and we need to consider them while planning anesthesia for such patients. Well, that was my last slide.
Thank you, Niskarsh, for that excellent presentation on the anesthetic concerns. Thank you for telling us about the pathophysiology and multisystemic disorders which are associated with obesity. And request you to stay back till the end because the questions will be at the end of all the talks. Please be with us.
Sure, sir. Sure,
Now I will request Dr. Madhuri Kurdi to share a screen. Share these slides. Dr. Madhuri Kurdi is from Hubli. She is the HOD of the KIMS Hospital, Hubli. She is very well known because of her involvement in Indian Journal of Anesthesia. And she is a well-known postgraduate teacher, and she has authored several articles and books, and she was a part of 2 national guidelines. So here we have Dr. Madhuri Kurdi with us to tell us about the pre-op risk assessment and optimization in obesity. Thank you, Dr. Madhuri, for joining us, and now the floor is yours.
Thank you, sir. Good evening, respected seniors, friends and colleagues of the Indian College of Anesthesiologists and respected chairpersons. First of all, I thank you for inviting me to this prestigious podium of the ICA. And I thank Dr. Muralidhar Kanchi, sir, for giving me this opportunity at the 134th seminar of the ICA. So my topic is risk assessment of the obese patient. Just one sec, I'm not able to move the slides. Are my slides moving?
No, I am seeing your CV slide.
Yeah, just 1 second. My slides are not moving. 1 second.
Yes.
1 second. They're not moving. Yeah. Yeah.
Yes. Now we can see the slides moving.
Yeah. I bring you warm greetings from my institute, Karnataka Institute of Medical Sciences, Hubli. Now, as Dr. Niskarsh has already told, that obesity is associated with various cardiorespiratory comorbidities, and obstructive sleep apnea is one of the common accompaniments of obesity, and most of the cases of obstructive sleep apnea are obese patients. And it is associated with obstructive sleep apnea is a very worrisome condition because it is associated with hypertension, cerebrovascular disease, and an increased all-cause mortality. And of course, about the Pickwickian syndrome, Dr. Niskarsh has just explained. That means if obesity is accompanied, is associated with so many problems, then that means risk assessment of the obese patient preoperatively is very, very important. Now is the era of risk assessment. By assessing the risk of the patient preoperatively, we can make plans or we can design our anesthetic management to suit the risk, and we can take proper precautions and advise the patient what to expect post-operatively. And by this way, we can improve the perioperative or the post-operative patient outcomes. So the risk assessment in obese patients, first of all, you have to risk the obstructive sleep apnea. That has been partly covered by Dr. Niskarsh. Then there is a risk of airway problems, which we have to assess. Then the assessment of the cardiac risk for non-cardiac surgery, because this obesity is associated with so many cardiovascular conditions. And the assessment of exercise and functional capacity is again very important. So the screening for obstructive sleep apnea, the most popular stop bang questionnaire, I think he has already explained it. Stop, what it stands for, and bang. And when the score is between 5 to 8, there is a very high risk for obstructive sleep apnea. So once you do the screening, if the score is somewhere more than 5, you know it's a very high risk. Whereas if it's somewhere intermediate, somewhere between 3 to 4, then the risk is intermediate. So here, some important factors come into the picture. If the score is more than or equal to 2 and it is a male patient, or if the body mass index is more than 35, or the neck circumference is more than 40 centimeters, then this intermediate risk becomes a high risk. Then we have one more parameter, that is the serum bicarbonate level. So in the Pickwickian syndrome, there is hypoventilation, so there is hypoxemia and hypercapnia, and the serum bicarbonate level is going to increase. And if serum bicarbonate is more than equal to 28, in addition to a stop bang score of more than equal to 3, then that means the risk for moderate to severe obstructive sleep apnea is very high. So the preoperative screening with a stop bang questionnaire in elective surgery has been found to be clinically very useful. And in this prospective observational study in patients posted for elective surgery, it was found that the percentage of post-operative complications in patients with high risk OSA was 9%, and the percentage of difficult intubation was 20%, and the percentage of difficult mask ventilation was 23%. And the higher body mass index and high risk for OSA were independently associated with risk for perioperative complications. Coming to the airway risk, a modified Mallampati score more than 2 predicts difficult laryngoscopy. Then a thyromental height more than 47 predicts difficult laryngoscopy. Neck circumference thyromental height ratio more than 7.9 predicts difficult laryngoscopy. And an inter-incisor gap less than 3 centimeters is again difficult laryngoscopy, and less than 2 centimeters indicates difficult supraglottic airway device insertion. Then if the patient is obese with a body mass index more than 26, with a beard, no teeth, and if the patient is elderly and a snorer, these are all part of the Bones criteria. And again, this 2 or more of these criteria, if present, they predict a difficult mask ventilation. So again, this observational cohort study, it showed that moderate and severe OSA were associated with difficult intubation, and an increase in the neck circumference is also again associated with the difficult mask ventilation. Then, you can do ultrasonographic assessment of the airway and find out what is the soft tissue thickness at different levels, the tongue volume, the hyomental distance, and volume of the floor of the mouth. All these can give you an idea about what kind of airway difficulty you're going to encounter, and what is going to be the level of your airway difficulty. Then comes the most popular and traditional ASA, the American Society of Anesthesiologists Physical Status Classification. So as you can see here, morbid obesity, BMI more than equal to 40, it falls in the category of ASA grade 3. And obesity, body mass index between 30 to 40, it falls in the ASA grade 2. Then, of course, if there are associated cardiovascular conditions, then they fall in other ASA grades like 2, 3, 4, depending upon how they are controlled. So, if as the ASA class goes on increasing, so here we have ASA grade 3, morbid obesity. And if the age is more than 70, then the predicted risk of mortality after major surgery is 30.6%. Whereas if the age is lesser, say it is less than 50, and the ASA class is 3, that the patient is morbidly obese, then the predicted risk of mortality is 12.4%. So that means age and ASA class both have to be considered together. Then comes the revised cardiac risk index. It is a very popularly used index to predict major cardiac event after non-cardiac surgery. And these are the risk factors: history of ischemic heart disease, high risk surgery, history of congestive heart failure, cerebrovascular disease, preoperative treatment with insulin, and preoperative serum creatinine more than 2. For each of these risk factors, there is 1 point. And as the number of risk factors increases, the rate of major cardiac complications increases. So if it is 3 or more points, then it comes in class 4, and the risk of major cardiac event, that is cardiac death or fatal MI following surgery, will be 11%. Whereas if it is 0 points, then it is class 1 and the risk is only 0.4%. Then comes the American College of Surgeons National Surgical Quality Improvement Program, the ACS NSQIP risk calculator. It is a web-based calculator. It is available on this. I will not enter it now, but if you enter in this site, you can automatically calculate the ACS NSQIP risk. So this is an online resource. And there are various criteria in this: the age group, the gender, the functional status, the emergency case, the class of the ASA physical status class, use of steroids, ascites, systemic sepsis, dependence on ventilator, disseminated cancer, hypertension, congestive heart failure, dyspnea, smoking, COPD, dialysis, acute renal failure, and calculating the body mass index. So it predicts the cardiac arrest and all-cause mortality, which may occur in 30 days. Then we have the Gupta's risk calculator, and this again is a web-based calculator which is available on this site. So it includes following criteria. There are 5 criteria: the age, the functional status of the patient, the ASA physical status, the serum creatinine, and the type of procedure you have to choose over here. And when you go on putting your values, it will automatically calculate the risk for you. So the outcome again here is the impossibility of intraoperative or perioperative MI or cardiac arrest within 30 days of surgery. And it is said to be having a somewhat improved discrimination over the revised cardiac risk index. Now comes the functional capacity of the patient, how you're going to assess it. You can do it either subjectively or you can do it objectively. So what we can do is subjective assessment you can do with the help of METs or the metabolic equivalents, which is nothing but the self-reporting of daily activities. So one MET is defined as basal oxygen consumption of a 40-year-old and 70 kg man in the sitting position, and it is around 3.5 ml per kg per minute. This is for the benefit of postgraduates, because this question is usually asked, how do you define one MET? So this is how you can find out what is the METs of the patient, by asking him questions what kind of work he's able to do, how much he's able to walk. If he's able to do strenuous sports, it must be more than 10 minutes. Whereas if he can just walk 1 to 2 blocks on level ground, then it must be less than 4 minutes. So patients with METs more than 4, you need not investigate them further and you can proceed with surgery. But patients with METs less than 4, well, the risk is quite high and these people need further preoperative evaluation. So METs more than 10 is an excellent functional status of the patient, 7 to 10 is good, and less than 3 is poor. Then you have the Sabrasi's breath holding test. All of us know this. So the patient takes a full breath and holds it as long as possible. If it is more than 25 seconds, you know that his cardiopulmonary reserve is normal. Whereas if it is less than 15 seconds, it is very poor cardiopulmonary reserve. Then the patient should have a 12-lead ECG taken in the last 3 months. Exercise stress testing can be done if the MET is less than 4. Pharmacological testing if the functional capacity is poor. And of course, coronary angiography in certain cases. And these baseline ECG, echo, all these will be affected technically because of the obesity. So the preoperative resting echo will give you an idea of the ventricular, systolic and diastolic function. It will tell you about the wall motion abnormalities, right and left ventricular hypertrophy and pulmonary hypertension, which are very common in obesity. The cardiac stress testing is very important and it should be done when METs is less than 4. This can be either exercise stress testing or it can be cardiac stress imaging. Cardiac stress imaging, you can see either reversible defects or isolated defects. So isolated fixed defects, if you see, then they are not predictive of an increased perioperative risk. Whereas if they're reversible defects, then they're indicative of an increased preoperative cardiac risk. Then you have transesophageal echocardiography, which is useful to evaluate the presence of coronary artery disease in severely obese individuals. You can also do a transesophageal dobutamine stress echocardiography. And this can be an alternative to cardiac catheterization for assessing the presence of coronary artery disease. Then technetium-99 perfusion scan can be used instead of exercise testing in very obese patients if you want to evaluate IHD. Then the cardiopulmonary exercise testing, it is said to be the gold standard and a specialized test, but not all institutes will have this facility. In this, the patient is exposed to incremental physical exercises up to a maximally tolerated level by using a cycle ergometer or a treadmill. And the work rate is gradually increased in a stepwise manner until the person is unable to continue. The optimal duration of exercise is 10 minutes. And what is recorded in this? Physiological variables recorded are ventilatory parameters, inspiratory and expiratory gases, blood pressure, and the electrocardiogram. And 2 key indicators are derived in this, that is the VO2 max, that is the body's maximum oxygen uptake, and VAT, that is the ventilatory anaerobic threshold. It is the point at which the anaerobic metabolism exceeds the aerobic metabolism. So, if the patient is unable to exercise at all, or if the anaerobic threshold is low, that is less than 11 ml per kg per minute, or if he is unable to achieve a peak oxygen consumption of 15 ml of oxygen per kg per minute, this corresponds to approximately 4 METs, then all this predict an increased risk of postoperative mortality in this patient. Then we have the Duke Activity Status Index, which is a self-administered clinical questionnaire. There are 12 questions in this, either yes or no, and there are points for either yes for a particular question. This measures the patient's functional capacity. You have to measure the sum of the yes replies, and from this you can calculate the VO2 peak. Then comes the incremental shuttle walk test. It is a very simple, reliable, and safe test. The person is made to walk at a faster pace every minute, and this is achieved by pre-recorded signals. And the test is ended when the subject is too breathless to maintain a rapid speed, or when he fails to complete a shuttle increment time. What is recorded in this? The blood pressure, the respiratory rate, the pulse rate, the dyspnea scale, all this is recorded. Then, of course, now is the era of biomarkers. So they can help you to do risk stratification. So the preoperative and immediate postoperative concentration levels of natriuretic peptides, troponins, and C-reactive proteins can predict the occurrence of MI and death at 30 days after non-cardiac surgery. Then you know that obesity is a very important risk factor to develop post-operative acute kidney injury. And then you have the obesity surgery mortality risk, especially in bariatric surgery. Risk factors include age more than 45 years, presence of hypertension, male gender, risk factors for pulmonary embolism, and body mass index more than equal to 50. So if the score is 4 to 5, it means that is the risk is high. And if the score is 0 to 1, the risk is low. Then, of course, there are various patient-related factors for high risk. If the patient is old, is a male patient, presence of comorbidity and hypoalbuminemia. And of course, the various types of risks attached to different type of surgeries, low risk surgery, intermediate risk, and high risk surgery. All of us know about this. And if the patient is old in age, more than 60 years, presence of COPD, congestive heart failure, prolonged duration surgery, high risk surgical type, and plan for general anesthesia, again, the patient can develop post-operative pulmonary complications. And preoperative PFTs can often help you predict post-operative pulmonary complications. You can do it with the help of microspirometers and ABG analysis. If the FEV1 is less than 1 liter with a normal PaCO2 and PaO2, the post-operative course will be normal. Whereas if it is less than 1 liter with a high PaCO2 and low PaO2, they are very likely to require post-operative ventilatory support. And if the FEV1 is less than 1 liter and the FEV1 by FVC is less than 40%, there is definitely going to be a need for post-operative ventilation. Now, once you know that this is going to be a risky case, you know that there are so many problems, you will have to optimize the patient. Optimize means what? You will have to, this can help improve the functional capacity and enhance the post-operative recovery. This can be done with the help of preoperative rehabilitation, which includes ask the patient to stop smoking if he's a smoker, try to reduce the weight before surgery if you have time for an elective case. Preoperative spirometry can be done for at least 7 days preoperatively, and preoperative nebulization can be advised. Now, when you do weight reduction, there are several benefits on the cardiovascular system. The blood volume, stroke volume, the cardiac output, the pulmonary capillary wedge pressure, the left ventricular mass, all of them decrease. The resting oxygen consumption comes down, the systemic arterial pressure, the resting heart rate, and the filling pressures of the right and left heart come down. And this is very beneficial to us perioperatively. So you can optimize the patient medically, psychologically, and do cardiopulmonary rehabilitation. If the patient has obstructive sleep apnea, you can give him some preoperative CPAP therapy. So prehabilitation can be multimodal. It can be multidisciplinary. Medical optimization of diabetes, hypertension, cardiac failure, cardiomyopathy, thyroid abnormalities, and optimizing the medications. So to summarize, it is very important to predict the risk in an obese individual preoperatively. And once you know the risk, you can take proper precautions and plan your anesthetic management accordingly. Thank you very much once again.
Thank you, Dr. Madhuri Kurdi, for that excellent presentation of pre-op risk assessment and optimization. Now, having gone through anesthetic concerns and how to risk assess and optimize patients, we'll go on to the anesthetic management. May I request Dr. Raghavendra to come up on screen and introduce Dr. Indrani Hemantkumar, who will be dealing with anesthetic management of bariatric surgery. Dr. Raghavendra, can you please introduce Dr. Indrani? It's my pleasure to introduce Dr. Indrani Hemantkumar, a very well-known and accomplished anesthesiologist of this country. She is currently Professor Emeritus, Seth GS Medical College and KM Hospital, Mumbai. Her areas of interest include pediatric anesthesia and obstetric anesthesia. As I said, she's an accomplished personality with several awards, including in the field of dance, Thank you for joining us, and we are sincerely grateful to you for joining us. And please enlighten us about the anesthetic management bariatric surgery. Thank you.
Thank you very much, sir, for your kind introduction. Kindly excuse my voice for today. I would like to thank ICA for giving me this opportunity to present this lecture on anesthesia for morbid obesity. The world is actually growing so obese, and tomorrow's anesthesiologist is going to deal with this every other day. I'm sure about it. So why are we worried about morbid obesity? It is a serious health condition that can interfere with basic physical functions, and it is associated with increased postoperative morbidity and mortality. Anesthesia in these morbidly obese patients is extremely challenging. And in the next few minutes, let's deal with it, how we are going to run through the anesthesia. I think Niskarsh already spoke about these things, but what I would like to actually tell you is, it's the pear shape of obesity and the apple type of obesity. So the peripheral obesity, we may not be so much concerned. Many of them just come for liposuction and things like that. But it is this central obesity who have a waist circumference, as already Niskarsh said, the ones which we are very worried, because they are the one who develop metabolic syndrome. They have all kinds of cardiovascular problems. They have difficult airway. Ventilation management is going to be a big risk, and the perioperative course may not be as easy as we can expect. So what are the type of bariatric surgery we may have to give anesthesia? One is malabsorptive type, where there is Roux-en-Y gastric bypass and the biliopancreatic diversion. And there could be a restrictive type of surgery where there is vertical banded gastroplasty, gastric banding, and sleeve gastrectomy. A short thing on what these are. Roux-en-Y gastric bypass, nothing. We are bypassing the stomach and the duodenum, and the jejunum is attached to the proximal gastric pouch. And in the second, biliopancreatic, similar, they're creating a mini sleeve gastrectomy of about 75 to 100 ml pouch, to which the ileum is attached. So this is the malabsorptive surgery, and the restrictive surgery is the vertical banded gastroplasty, where there is surgical creation of a gastric pouch that can accommodate a 25 to 30 ml of food only. So it is a baby stomach. Laparoscopic adjustable gastric banding is very popular, and sleeve gastrectomy, wherein the stomach is approximately slashed to 20% of its original size. So with all these, so what problems can we expect in a morbidly obese patient? They come with multi-system comorbidities. Niskarsh dealt with it in a very nice way. And you find that the patients can have cardiac complications, pulmonary complications, the kidney injuries, liver may be affected, then they can have stroke, they can easily develop sepsis. And as I said, every system is affected with obesity. Now, I'm not going to deal with them. I think all this is easily or is already done. Now, coming to this is one of the most important slide I would like to show, and I want everybody to please concentrate on this slide. It goes without saying that we are dealing with a very high-risk case, and a thorough history and physical examination is mandatory in each and every patient. Apart from knowing what are the cardiac status, patient may be having coronary artery disease, patient may be having hypertension, patient may say, I get palpitation, I get little bit of giddiness. So which means patient may be having arrhythmias. Patient will say, I get breathless even if I walk 10 steps. Patient with orthopnea, syncope, renal issues. patient may, you have to ask history of any DVT, whether they have DVT, whether they have history of gastrointestinal problems as in GERD or hiatus hernia, whether it has been evaluated. More importantly, pulmonary evaluation is very, very important. Again, find out how much the patient can walk. At least, can the patient reach up to 4 meds? If we are not dealing with a patient who can reach even up to 4 meds, remember, we are dealing with a very, very high risk patient. So, and many a times, why many a times? Almost all of them will be diabetic. You have to find out is it under control, whether the patient is on oral hypoglycemic agents, whether they are on insulin, any skin condition. Most of them, they are not able to even wash their feet. They are not able to bend. Many of them have, skin issues for which steroids have been advised. So are they on those steroids? So then that's another thing which you have to keep in mind, whether in the preoperative period. And again, were they on any diet drugs? Many of them, they try everything under the sun to lose weight, like any shortcuts to lose weight, I would say that is using herbals, over-the-counter drugs, things like that. And I would like to quote one incident where a famous actor was on the table, and when the multi-para monitor was attached, he was throwing one hell of a lot of BPBs. No one knew why it was happening. And when the cardiologist was called and everybody was called, then the surgery postponed. And when they found out, he was on herbals. So remember, you have to ask this history to each and every one of them. And how is the airway? You have to evaluate the airway in the preoperative period. So is the patient having a beard? Do you think you might have a problem with mask ventilation? All these has to be done. And if you feel that, even the neck is not visible, tracheostomy will be a challenge. Front of neck axis also will be a challenge. So, and do you think you may, and potentially they are all difficult intubation. So all of you should have the difficult airway guidelines in your fingertips when you're dealing with such patients. So also at this point of time, please measure the saturation in room air. It has to be at least 95% and then also ask for any history of any admission, hospitalization for metabolic syndrome, or any cardiac event, for which they have been admitted. So, or if the patient is having OSA and its problems associated like pulmonary hypertension and things like that. So if you dealing with such a patient, remember, you're dealing with a very high risk patient. Patient may be having, DVT with prophylaxis measures, maybe on low molecular weight, heparin. So all these have to come in your history. You have to identify and make note of all the points. Remember, the metabolic changes they may have deficiencies, calcium, iron, vitamin, other protein deficiencies also. So multi-system comorbidities evaluation is a must in all these patients. So I think pre-anesthetic evaluation was completely very well dealt in the earlier by Niskarsh. So, but what I would want to tell you is when the patient comes for a bariatric surgery, it's good to have this score called the Obesity Surgery Mortality Risk Score, wherein you identify risk factors such as arterial hypertension, age more than 45, male gender, and a BMI of more than 50 kilograms per meter square, and risk factors for pulmonary hypertension. All of them are given on 1 point. And if the patient has 0 to 1 low risk of mortality, 2 to 3 intermediate risk of 2% mortality, and anything more than 3% is a very high risk of mortality following a bariatric surgery. Preoperatively, please keep in mind, these are the patients who have small mouth, short thyromental distance, increased neck circumference, decreased neck mobility, large breast and tongue. More than anything, please also remember these are the anatomical barriers for you when you want to intubate the patient. Apart from that, remember their airway diameter as compared to a normal person. Look at the airway diameter of a normal person and look at the airway diameter of an morbidly obese patient. So it is reduced tremendously in these patients. So that makes it very difficult for us as anesthesiologists. They have a challenged physiological airway too. The reduction, so Niskarsh also told you in detail about them. And these can lead to decreased time to saturation, presence of bronchospasm, presence of atelectasis and pneumonia in these patients. So remember that these are the patients who have increase in oxygen consumption and carbon dioxide production. They have increased work of breathing. All of them can lead to hypoxemia and hypercapnia if ventilation is impaired. And excessive adipose tissue reduces the chest wall compliance, reduces the FRC to the closing capacity, leading to atelectasis, even with tidal breathing. And a further reduction in FRC, remember, will happen with general anesthesia, and a much further reduction, especially when you take up the patient for a laparoscopic surgery, when you start giving pneumoperitoneum to these patients. Now coming to airway management. One of the nightmares is the airway management in these morbidly obese patients. Difficult intubation, is there any doubt? Yeah. So the question is, how are you going to give position? Sniffing of the morning air position for laryngoscopy. Is it easy? Next, giving RSI. So there was a time when every single patient would be given RSI because people wonder, we went with that obesity causes regurgitation and aspiration. Whereas there is no further doubt that despite presence of hiatus hernia, diabetic neuropathy causing delayed emptying, the evidence reveals that obesity alone does not increase the risk of pulmonary aspiration. Please give me a minute. So each and every patient does not need an RSI. However, if a morbidly obese patient also has other issues wherein aspiration is possible, as in kidney failure or things like that, you may be giving RSI to this patient. I'll come to that. Whether the patient has to be taken awake or under anesthesia, whether do we need to give an awake fiber optic intubation, or are you going to take the patient under anesthesia and intubate the patient? Earlier, there used to be please remember, each and every patient doesn't need awake fiber optic intubation. Remember who's the one sitting in front of you, whether you will be able to manage yourself, how much of help you will need, what equipment you have to keep in with you. All this has to be done taking into consideration your own expertise. Please remember to take help when you need. Front of neck access is going to be very difficult. So it may be appropriate maybe to do an ultrasound and see the depth of cricothyroid membrane in these patients. So the 5 P's are preparation, pre-oxygenation, pre-treatment, paralysis, placement of the tube, and post-intubation management. These are the key to airway management. Coming to the intraoperative anesthesia management, I would want to look into each one of them separately. One is airway management, maintenance of oxygenation, patient positioning, monitoring, and maintenance of anesthesia. So these are the patients where you have a difficult intubation, a difficult mask ventilation. So one thing is about how are you going to manage this difficulty of mask ventilation? One is, and not just mask ventilation, remember these are the ones for difficult supraglottic airway device insertion also. Please remember that. So how are you going to mask ventilate? There are various ways. You can use four-handed technique, use oropharyngeal, nasopharyngeal airway. Remember, always increase the safe apnea time by giving a PEEP or a CPAP of 10 to 15 centimeter of water, giving apneic oxygenation, and use of HFNO. So the one way of easing yourself is to give a standard, a reverse 30-degree Trendelenburg position. That increases the apneic time by more than a minute. That itself, it reduces the peak airway pressure. It reduces the alveolar to arterial oxygen difference. So the position which has to be given in these patients is the ramp position. Look at this picture. This picture is using a standard pillow. So just a head cradle has been given to this patient. So the oral, pharyngeal, and the laryngeal axis are so badly misaligned. And if you try to mask ventilate or even try to intubate this patient, it's going to be impossible. So the good airway position here is to use a troop elevation pillow. This gives a ramp under the shoulders of the patient. And to this, you have to add the pillow on top. And by doing this, what we are trying to achieve is that we align the upper body, the ear tragus to the sternal notch. The tragus to the sternal notch is aligned. And by doing so, the oral, pharyngeal, and the laryngeal axis are aligned. The neck is also opened up in this position. So we have to use this position and call the ramp position for intubation, otherwise called head elevated laryngoscopy position, for which you can use the table also to elevate. So this position offers advantage of increased comfort for the patient. Functional residual capacity is maintained, reduce the dyspnea, bag mask ventilation is facilitated, and laryngoscopy is improved. Now, pre-oxygenation and recruitment maneuver. Pre-oxygenation, you have to give a good 3 to 5 minute pre-oxygenation with 100% oxygen. You can use nasal cannula, flow at 15 liters per minute. You can also use HFNO. You can use both nasal cannula as well as HFNO for pre-oxygenation. Again, as I said, recruitment maneuver is a must because it gives a sustained lung inflation of 55 centimeter water for 10 seconds. And then, or you can apply, this is the 50-10 technique, or you can use a CPAP PEEP of 10 centimeter of water, and that prevents atelectasis and it recruits more of your alveoli. And this increases the safe apnea period during induction. So what is safe apnea period? It is the time between the muscle paralysis and apnea until the SpO2 drops to a potentially dangerous level. So in a normal patient, it will be about 8 to 10 minutes. Even if you don't ventilate the patient, the saturations don't drop to dangerous levels. However, the same in an obese patient will be barely 2 to 3 minutes. So as I said, how do you increase the safe apnea period? By apneic diffusion, apneic oxygenation, where you have diffusion of oxygen using the Thrive or the HFNO, or you can use your CPAP oxygenation. So in apneic oxygenation, the oxygen diffuses at 250 ml and carbon dioxide comes out at 10 ml per minute, generating a negative pressure gradient. And that's how it helps in the increasing the safe apnea period. Thrive It gives 70 liters per minute of humidified oxygen. It is associated with flow-dependent dead space flushing, resulting in gas exchange. It gives a CPAP of almost 7 to 10 centimeter of water. It also opens up the airway, and successfully it is used to pre-oxygenate patient at high risk of hypoxia during intubation and maintain oxygen saturation up to 40 liters per minute. So this has become a game changer for morbidly obese patient. So the only disadvantage being progressive hypercarbia with acute respiratory acidosis. Coming to laryngoscopy and difficult intubation in these patients, well, are all of them a difficult laryngoscopy and intubation? No, they may not be. BMI is not a powerful predictor for difficult laryngoscopy and intubation. Remember? However, also remember that they are potential difficult intubation. They have short neck, thick neck, large tongue, large amount of pharyngeal soft tissue, abundant pretracheal soft tissue, and a large breast. And especially if the neck circumference is very high, then the difficulty is going to be about 35 to 40%. And also if the Mallampatti is more than 3, you can expect a potential intubation problem in these patients. So keep your difficult airway cot ready. Gum elastic bougie, ventilating bougie, oropharyngeal, nasopharyngeal devices, stubby handle, LMAs, long tracheostomy, tube, video laryngoscope, fiber optic bronchoscope. Remember, yes, fiber optic bronchoscope. It should not be taken as your routine for intubating the patient. Remember, you should identify those patients who have a specific reason for using a fiber optic bronchoscope. Anybody with, say, cervical spine issue, things like that. Or if you're really worried about, it's super obese. So these are the patients you will look into a fiber optic bronchoscope, not all of them. And of course, a set for needle and scalpel cricothyroidotomy. So who are the ones who you're expecting a difficult ventilation and laryngoscopy? As I said, Mallampatti score more than 3, neck circumference more than 42, BMI more than 50, presence of beard, and symptoms of georeflexes. Well, do you want to use a direct laryngoscope or a video laryngoscope? Is it a question anymore? No, video laryngoscope reduces the number of failed intubation attempts by improving the glottic view. It also decreases the chances of laryngeal or airway trauma. It also decreases the number of intubation attempts. In the incidence of hypoxia, however, is the same with both. So coming to induction, please remember, use gel pads to protect pressure points. I'm going to repeat it again. Aspiration prophylaxis, H2 receptor antagonists, PPI like pantoprazole, antiemetics have to be given in the beginning. Our main concern is hypoxemia and gastric regurgitation at this point of time. So you have to give these drugs before you give your induction drugs. And decision about RSI or a standard induction without RSI, that depends on patient's risk of difficult mask ventilation or intubation and other causes of aspiration other than obesity. As I already said, we don't want, air entering the stomach and inducing aspiration. So if you feel that mask ventilation is going to be really, really difficult and you don't have enough help, then that's when you would want to use an RSI. Now coming to maintenance, use of drugs. Here I cannot go without talking about total body weight, lean body weight, and ideal body weight, because you have to know what this is all about when we are dealing with drugs. Total body weight is the actual weight. If the patient is 220 kilograms, it's 220 is the ideal, it's the total body weight. Ideal body weight is what the patient should weigh with a normal lean to fat mass. So ideally for that height and weight, what should be the weight? That is ideal body weight. And then that is estimated using only the height of the patient. Whereas lean body weight is the patient's weight excluding the entire fat in him. So then that is calculated using both the height and the weight. Whereas ideal body weight is calculated only with the height. Lean body weight is calculated with both height and weight. So there are formulas for both. So coming to anesthetic agents and their doses. How are you going to, which body weight are you going to use for loading dose? Which one for maintaining dose? So lean body weight is one where the drug is mainly distributed to the lean tissue. Total body weight means we are distributing the lung both to the adipose tissue and to the lean tissue. So for the maintenance dose, a drug with similar clearance values in both obese and non-obese patients can be used with any patient where we are using drugs using lean body weight, whereas with total body weight, clearance increases with obesity. So let us look at the drugs and their dosings. Drugs with weak or moderate lipophilicity can be dosed on the basis of ideal body weight or more accurately on lean body weight. Non-depolarizing neuromuscular blockers can be dosed in this manner. So these are having moderate lipophilic property. So you use it according to the lean body weight or the ideal body weight. Induction dose of propofol can be calculated on lean body weight. Midazolam can cause prolonged sedation from the larger initial dose needed to achieve adequate serum concentrations. So succinylcholine should be calculated based on total body weight. Rest, fentanyl, bupivacaine, neostigmine, antibiotics, all of them should be based on lean body weight. Neostigmine, no more than 5 milligram should be given to these patients. During induction, large doses of induction agents may be required as the blood volume, muscle mass, and cardiac output increases linearly with the degree of obesity. Propofol is given up to 2 to 2.5 milligram. And I said use the lean body weight for the induction dose of propofol. So in maintenance, this is not for bariatric surgery, but if you're giving it for a non-bariatric surgery, you have to go by total body weight for propofol. Succinylcholine, as I said, go by total body weight. It is highly recommended for tracheal intubation. So succinylcholine has not gone out of vogue because it the increased dose as pseudocholinesterase trace activity is also increased in these patients. We can use any of the following drugs, non-depolarizers, for maintenance or even induction if you're good enough. So rocuronium, vicuronium, atracurium, cisatracurium, any of them can be used. Maintenance would be fentanyl, 1 to 2 mics per kilogram according to lean body weight, or you can use sufentanil. It's coming up in the market. Remifentanil is coming in the market, again, lean body weight. One of the problems during induction is awareness. So the NAP5 study revealed an increased incidence of awareness in obese patients shortly after induction of anesthesia. So remember, you may have to further give IV boluses before airway manipulation in these patients. You should be able to start a dexmedetomidine infusion to reduce the anesthetic requirement according to the total body weight at 0.5 to 0.7 mics per kilogram per hour. As I said, neostigmine, no more than 5 milligram, glycopyrrolate according. So what about in use of inhalational agents? Now we have the era of desflurane, which is totally insoluble. So it gives the advantage of fast induction and rapid recovery. And so desflurane has got a low partition coefficient of 0.42, and that would be my choice of inhalational agent. Nitrous oxide can be used, reconsider it even in laparoscopy. And if the patient is having cardiac issues, you should use sevoflurane. How are you going to position the patient? You can use 2 tables, OT tables side by side. All pressure points have to be padded because we don't want any pressure source and nerve injury in these patients because they go in for a steep reverse Trendelenburg position and they are prone to slip from the OT tables. They have to be strapped up to the footrest and difficult. So it's also difficult to put an axillary roll. And the positioning generally carried out in Lloyd Davis position. and with a Trendelenburg position, with reverse Trendelenburg with legs spread apart and both arms out on arm boards. Close attention should be paid, as I said, because we don't want any compartment syndrome or nerve injury, and more chances of endobronchial intubation during position. So please check please auscultate your chest after positioning also. Say after positioning, what can happen with a steep reverse Trendelenburg position? There is a decrease in venous return, and that can lead to hypotension. So to counter that, you have to give proper hydration, give IV fluids to this patient, keep inotropic support also ready in case. Gastric calibration tube is inserted. It is used to guide the upper pouch preparation by stapling the stomach. A leak test usually is done after the first anastomosis. And when they do the leak test, remember there can be chances of aspiration. This is how the patients are positioned here. And yeah, so this is again a strap. The legs are given. You can use for DVT. You can use the socks for DVT in these patients. So what of monitoring? Standard monitoring. Not that everyone needs an invasive arterial BP monitoring. It depends upon the comorbidity of the patient. And if you have an invasive BP monitoring, you can do dynamic indices like SVV and PPV to monitor how much of fluid you want to give. PA catheter, I would not suggest a PA catheter. However, if the patient has pulmonary hypertension with cor pulmonale, you may think about you putting in a PA catheter. Non-invasive monitoring, NIBP will be very difficult. So most of the time you have to put the cuff. You don't get that exact cuff. So you may have to put it on the forearm, or you have to use neuromuscular block monitoring, other monitoring like BIS monitoring, because as I said, awareness is very common in these patients, and standard monitoring, temperature. You can use forced air blankets, fluid warmers. CVP line you may have to use because peripheral line is difficult to secure. Intraoperative mechanical ventilation, there's a full lecture on that, but please remember that lung protective ventilation with a plateau pressure less than 30 centimeter and titrating the PEEP to about 8 to 10 centimeter depending upon the respiratory and the cardiovascular state of the patient, and use of PCV more than VCV in these patients would help. So as I said, you can use all kinds of recruitment maneuvers, which I've already told you, FiO2 from 0.5 to 0.8, depending upon how the patient is doing with you. That you have to assure acceptable oxygen level. And remember, too much of FiO2 also can cause absorption atelectasis. How are you going to manage fluid? Patients may have hypovolemia because of earlier bowel preparation, pre-op fasting, fluid according to the IDA body weight, urine output, and blood loss. Normovolemia should be your goal. Rapid fluid administration should be avoided, especially in presence of cardiac issues. Central CVP monitoring, as I said, blood loss is usually greater as compared to a non-obese. However, most of them don't need blood. Remember, if there has been intraoperative hypertension or prior renal disease, or if the BMI is more than 50%, patient may have postoperative acute tubular necrosis. Extubation should be done in a semi-recumbent position. Trachea, the muscle relaxant dose should be guided by neuromuscular monitoring. Full reversal of neuromuscular blockage should be confirmed before extubation, having a TOF score of more than 0.9. Patient's lung should be ventilated with 100% oxygen, and trachea should only be extubated once the patient is able to obey commands and maintain spontaneous ventilation with adequate tidal volumes. So remember, these patients have been on CPAP earlier also. Post-op also, patient will need CPAP mask ventilation, especially if they are suffering from OSA. Shift the patient to a PACU or a HDU. Extubation may also be done using an airway exchange catheter or even a Bailey's maneuver. Here we have to decide where the patient should go, whether to HDU or to PACU. We have this Montefiore obesity surgery score, wherein patient, if they have more than 4 of these criteria, they have to be shifted to a high definition, HDU, like gastric bypass surgery, male gender, BMI more than 50 kilogram per meter squared, age more than 50 years, confirmed diagnosis of OSA, significant medical or surgical comorbidities, and a previous abdominal surgery. Thank you very much.
Dr. Indrani, that was lovely overview of anesthetic management for bariatric surgery. Very well done. Thank you for highlighting the problem with herbal medications and the differences between the total body weight, lean body weight, and the ideal body weight, and how to deal with intubation problems and several other things, monitoring issues. Thank you so much. Please stay till the end of the session. In spite of your the throat, you have done very well. Congratulations. Thank you very much.
Thank you.
Now I would like to invite Dr. Rangalakshmi to tell us about the perioperative complications and management. Now we have done the surgery, we have done the physiology, then pre-op assessment, then the anesthetic management. Now we come to complications. Dr. Rangalakshmi, a very accomplished anesthesiologist. She's the professor and head of anesthesia at the renowned Rajarajeshwari Medical College and Hospital, Bangalore. And she's again one of the shining stars in the sky of anesthesia horizon. And Dr. Rangalakshmi, please tell us about the perioperative complications and management. Thank you so much for joining us.
Thank you, Dr. Murli, for your very kind introduction, and I'm grateful to ICA for having me here. I'm going to be talking about, one sec, again, my slide is not moving. I think I'll have to go back and do it because
Ma'am, you can try with the arrow keys as well.
yes, I did, but I'm just going to share my presentation again. Yeah.
Just click on the slide.
Yes.
Click again.
Yes. Yeah, I got it.
Okay.
Yeah, thank you. So great. I'm going to be, can I start? Yeah.
Please,
so,
please.
Yeah. Thank you, Dr. Murli and ICA for having me here. I would like here to pay homage to Dr. Kumara. I am an alumni of Safdarjung Hospital, Delhi. And Manorma Mittal and all have been my teachers. So I'm going to be talking about perioperative complications in obesity and their management. I will try and skip over some of the things which have already been said. While I'm talking, what I would like to say is that very briefly, some indices which have not been mentioned or some recent literature about this, then some of the factors determining the incidence and severity of postoperative complications and the complications themselves. This has been gone on enough and more, so I'm not going to be telling about this. Now, ISA brought about some practice guidelines, and they published in Anesthesiology in 2014, which was by a ASA task force. And they had some new risk factors. This is yet to be validated, though. But what they said was that the severity of sleep apnea itself, based on sleep study, with invasiveness of surgery and anesthesia, and the requirement of postoperative opioids. You add A to B or C, whichever is higher. And what they said was that a patient of 5 or 6 are maybe significantly increased perioperative risk from OSA. This is another score which came, which said that the bariatric surgery index for complications again published, where they added that if the patient is already on anticoagulants, COPD, dyslipidemia with a psychiatric history or revisional surgeries, any more than 3 risk factors was considered higher risk. Then this was an interesting study where they say that the more the surgeries the surgeon does, the less is the risk, was already told. And moving on to the complications per se. Any kind of hernia can occur. These are the general complications, which may be incision hernia, all types of hernias. Then procedure specific, all these gastric remnant distension, stomal stenosis, nephrolithiasis, etc. And occur. Finally, there can be failure to lose weight per se. As far as we are concerned, there is a real risk of pharyngeal collapse, especially during sleep in the postoperative period. So what we need is a competent and an efficient postoperative management team. And life-threatening obstruction can occur, remember, for several days postoperative. When the patient is shifted to PACU, we expect the criteria of extubation would have been met. We will recheck again. And we try to prevent, the objectives are to prevent the occurrence of airway obstruction with proper ventilation, prevent collapse of the lung, which supports better gas exchange, and restore and preserve at least as normal respiratory functions and possible. These patients have to be triaged, as told previously. We have had some triage criteria also. They are transported wide awake with either oxygen through a cannula or a face mask with an NIPP device and or a nasal CPAP device. Normally, they did not require an ICU, but a PACU where high-risk patients can be put, again, depends upon the severity of OSA, or even an intermittent care observation unit with high nursing ratio should be enough. From then on, they are moved to a step-down unit. And the monitoring in the post-operative period is mostly routine. There is one interesting article which I came across which said, this was published in 2021, which said that a transcutaneous carbon dioxide is as effective in reflecting the arterial carbon dioxide levels as a capnography. So the complications, the cardiac complications, quite a few have been said, has already been said by the previous speakers. I will just touch briefly on it. However, it is the respiratory early complications which we are very concerned about. And that is post-anesthetic hypoxemia occurs almost in 70 to 75% of all obese patients, whether it is bariatric surgery or otherwise. This occurs also, we also know that nowadays a lot of bariatric surgery happens through laparoscopy. So residual pneumoperitoneum, peritoneal irritation, air in the stomach due to residual anesthetic, muscle relaxant, or any other inhaled anesthetic. Positional ventilatory collapse, we know that the PFT is already deranged for such patients. We have to watch for respiratory depression. Now, I have tried to find the criteria. Some literature said that a respiratory rate, we need to observe this, and they are not necessarily the rule, but a general pointer. An oxygen saturation of less than 85, all these should last because transient it will occur in most of these patients. More than 20 seconds, a low respiratory rate, a low oxygen saturation, an EtCO2 which is high for more than 20 seconds, and an apnea episode which lasts for more than 20 seconds. Why do we have? We all know that intra-abdominal contents shift the diaphragm rostrally, and this has also been told the physiology of obesity. Now, this was why I have put this is, see, Prodigy score, this was published in 2020, where they tried to predict the opioid-induced respiratory depression in the ward after surgery. One of these factors was sleep-disordered breathing. The others you can see here. Now, they gave a risk score or a Prodigy risk score, which predicted the postoperative respiratory depression. However, when this gentleman, Mark Abbott, tried to validate it in opioid sparing bariatric surgery, what he found was that, in fact, the postoperative respiratory depression is purely related only to the OSA status and not an elevated prodigy score. That is, the other factors do not come here. Now, prevention of postoperative atelectasis, nowadays it's quite uncommon because 90% are performed laparoscopically. So an early ambulation, avoid prolonged recumbency, and careful titration of postoperative analgesics prevents splinting. It's very important that you give good analgesia. And as Madam Indrani has already told before me, a recruitment maneuver followed by PEEP before extubation does reduce the postoperative atelectasis. Patient has to be given oxygen therapy until at least the preoperative oxygen saturation levels are achieved. Normally at 24 to 72 hours should be sufficient. Susceptible patients, we do give positive airway pressure also. Nowadays, a lot of surgeries are done ambulatory for a lower degree of OSA, again, for this, or rather obesity itself. But again, in this ambulatory surgery also needs monitoring for at least 7 hours. When there is a hypoventilation syndrome, they have to be given CPAP or BiPAP. I will tell you about the pressures in the next slide. And they are recovered in a semi-Fowler position, which is about 30 to 45 degrees up, and which decreases the superior vena cava pressure, and the positional injuries are also to be taken care. In the postoperative period, CPAP, when given, recommended pressure is about 8 to 12 centimeters of water. Where if you're giving IPAP, and inspiratory peak pressure of 12 with an expiratory peak pressure of 4 should be enough. If you're using pressure support ventilation, again, a pressure support of 5 to 10 centimeters of water with a PEEP of 5 to 10 centimeters of water, please use it. Also, there are so many now available CPAP machines. Some of them give what is known as auto CPAP. Now, auto CPAP is supposed to detect variations. As we know, these people are really prone to obstructing in their sleep. They detect variations in obstruction and adjust the pressure levels accordingly to reduce breathing. However, while people have tried to validate it, they have found that it's still controversial whether it's better than a fixed CPAP. This was morbidly obese patient we operated recently in our hospital. She was about 150 kilos, and she had a debridement in her leg. As you can see, she is obstructing, and this was post-operative. And what we did was, this was a debridement to be done. There was a superficial gangrene. We put up the position and we gave her a femorosciatic block. It was quite effective, an ultrasound guided block, and the patient is now better and shifted to the ward. What about other complications? Major adverse cardiac events, this has already been gone through. All kinds of cardiac events can occur. Post-operative, depending upon the preoperative comorbidity, fibrillation, stroke, atrial fibrillation, thromboembolism, and congestive cardiac failure. So the treatment are standard treatment protocols. Just one thing I would like to add on this, while antihypertensive agents, statins and aspirin, we talk about anesthetic drugs. These are also, the loading doses are dosed on lean body weight, but the maintenance doses are adjusted according to the clearance alterations. Sometimes total body weight is also used. One more thing which I found in literature was that vasopressors can be titrated because they are titrated to a rapidly clinically observable effect. You can use total body weight in certain instances. The other complications which can occur are hemodynamic instability, positional injury, especially all kinds of neuropathies can occur. I'm going to be just touching upon venous thromboembolism and postoperative nausea and vomiting, rhabdomyolysis, which can lead to AKI, postoperative cognitive dysfunction can also occur, and wound infection. These surgeries, especially bariatric surgery, the bypass ones, are highly emetogenic because they interrupt peristalsis, so the gastroesophageal anti-reflux mechanism is lost. Then the emesis is increased by an anastomotic kink or any other surgical related cause. There is increased release of 5-HT. And this 5-HT, because it is stored in enterochromaffin cells, there is increase, which leads to increased PONV. Prevention is always better than cure. Nowadays, a lot of people are following this enhanced recovery after surgery protocols with gabapentin, opioid-free anesthesia. Dexmedetomidine is given perioperatively. Ondansetron, as already told, is given preoperatively. Another anti-emetic which is added is aprepitant, which is a neurokinin 1 inhibitor. It has a very long half-life, so the prevention or the cure occurs to or extends to almost 2 days in the postoperative period, can be supplemented by corticosteroids, especially dexamethasone, or butorphanones, both either droperidol or haloperidol. What about venous thromboembolism? Obesity itself is a risk factor for thromboembolism. Prophylactic use of low molecular weight heparin is recommended. Again, dosing for a slightly lower BMI, that is 30 to 39 or up to 40 to 45. Also, standard dosing protocol can be used. Some also use weight-based protocol, that is 0.5 mg per kilogram. This is again dosed on total body weight. High risk bariatric surgery, especially more than 50 kilogram per meter squared BMI, we give 60 milligram of low molecular weight every 12 hours. All this, we presume that patients have a normal kidney function and they are given subcutaneously. What about analgesia? Again, ERAS protocols are, the postoperative pain is substantially less. Preemptive analgesia is often given from wound infiltration before and after surgery. Any non-opioid drug combinations such as ketorolac, clonidine, lignocaine, ketamine, methylprednisolone is supplemented. These patients often have an esophageal spasm-like pain in the postoperative period. This can mimic MI. There's no need to panic. Antacids and H2I receptor antagonists are good. There are still people who use intravenous infusions of opioids, which is by patient-controlled analgesia. Transversus abdominis pain block and erector spinae block have been effective as part of multimodal analgesia. Both thoracic epidural analgesia or patient-controlled epidural analgesia can be used. Remember, in epidural analgesia, the dose is increased up to 75% because of the decreased volume of epidural space from increased intra-abdominal pressure. Epidural itself is difficult in such patients. Sitting position can be used with an ultrasound, and they can be a failure as in any other patient. This is a regimen which has been recommended by some, which is a combination of celecoxib, acetaminophen, a gabapentinoid, and an aprepitant. This is going to be by the next speaker. We discharge from the PACU when the patients have unsupported vital signs with no evidence of ventilation, be free from apneas without stimulation, and they are able to use a CPAP device if required. I conclude by saying that bariatric surgery has progressed by leaps and bounds, nevertheless still challenging to manage for an anesthesiologist. And we expect, as anesthesiologists, unexpected, unforeseen, and unanticipated situations in the perioperative and the postoperative period, which requires vigilant and attentive monitoring along with awareness of the postoperative complications. These are my references. That's my department for you. Thank you very much.
Thank you. Lovely talk once again. Thank you so much. And you have touched upon several important points in the postoperative management. And thank you for highlighting the new scores which are available in assessing these patients, especially Prodigy score and the use of postoperative oxygen BiPAP, etc. You also mentioned that the vasopressor dose must be based on total body weight, very important point. And you touched upon postoperative nausea and vomiting and how to avoid venous thromboembolism. Thank you so much. Please stay back till the end of the session for the question answer session.
Thank
And
you,
it's
sir.
my pleasant, thank you so much. It's my pleasant duty to call the last but not the least speaker, Dr. Rakesh. He will be talking to us about the perioperative mechanical ventilation, how to ventilate these patients, the obese patients with reduced compliance, maybe restrictive lung disease, etc. Can we have Dr. Rakesh share his screen?
Good evening. Can I request Madam to stop sharing the screen, please?
I'm sorry.
Thank you. Thank you so much. Dr. Rakesh is a colleague of mine in the multi-specialty hospital in the Narayana Health City. He is very enthusiastic and upcoming anesthesiologist with a lot of promise. Rakesh, can you share your screen?
I'll start 1 minute. It's come up, sir.
Yes, yes, please carry on.
Okay, my topic is perioperative mechanical ventilation, special consideration in obesity. I thank ICA and Muralidhar sir for giving me the opportunity to speak on this forum. I'll be covering I don't have any disclosures. I'll be covering the topics in these subheadings: introduction, challenges for ventilation, strategies to overcome the challenges, and a brief summary. Ventilating obese patients is becoming a frequent challenge since the prevalence of obesity is steadily increasing and reaching epidemic proportions worldwide. In India, according to the ICMR India study in 2015, the prevalence rate of obesity has increased from 11.8% to 31.3%, and central obesity among these has increased from 16.9% to 36%. Although it's unproven that obesity per se increases the risk of postoperative pulmonary complications, reports of postoperative hypoxemia, ICU admission, and other resources use and hospital length of stay are often greater, especially in the presence of severe obesity and or sleep apnea. Mechanical injury to blood gas barrier is a hallmark of ventilator-induced lung injury. Cyclical opening and collapse, that is adlectotrauma of alveoli, can trigger and amplify a local inflammatory reaction of the lung, that is called a biotrauma. Compared with conventional ventilation with a tidal volume of 10 ml per kg predicted body weight, protective ventilation with lower tidal volume, that is 6 ml per kg body weight, increases the number of ventilator-free days and reduces the in-hospital mortality by decreasing the inflammatory markers in the lungs. Now, we're coming to the challenges. There are physiological changes that occur in obese patient. One of them is the decreased compliance because the chest wall is more than the lung. That is because of the increased deposition of the adipose tissue. The challenge because of that is decreased compliance during mechanical ventilation. We'll have to use higher pressures to ventilate this lung. There is increased oxygen consumption due to increased metabolism, due to increased tissue, that is adipose tissue, as well as increased carbon dioxide production because of the increased tissue. Second thing is there is increased work of breathing. So because of that, the chance of frequent desaturation occurs, which is a challenge for us. The next one is a decrease in FRC and end expiratory volume, lung volume, especially in supine postures. And as Madam had said, with laparoscopic procedures, and sometimes we do non-bariatric surgeries like hernias and all, which the patient will require Frenland-Berg position. During this time, the chance of atelectasis and increased work of breathing is very high. The FRC goes below the closing capacity, and because of that, auto PEEP and rapid desaturations can occur. Post-operatively, the major respiratory concerns in obese patients are related to the increased risk of hypoxemia and respiratory failure. They could be related to opioid-enhanced central respiratory depression, upper airway obstruction, which is the most common cause, and hypoventilation atelectasis. What strategies do we use to overcome these challenges? Pressure-controlled ventilation is often the preferred ventilatory mode in obese patients because of the more homogeneous distribution of delivered gas mixture and the increased possibility of avoiding alveolar distension and improving ventilation perfusion mismatch when compared with volume-controlled ventilation. But studies have shown that PCV and VCV are almost similar in the final outcome measures. Intraoperatively, it improves all these parameters. The ideal or predicted body weight should be used when setting the tidal volume on the ventilator, since lung size does not change with the increase in body weight. Ideal body weight, as that word, it can be easily calculated using the height in centimeters minus 100 for male and height in centimeters minus 105 for females. The newer ventilation mode that has come recently is the pressure controlled ventilation volume guaranteed. It has been, it is a time cycled pressure regulated mode with a variable inspiratory flow to achieve a preset tidal volume. PCV-VG poses some theoretical advantages in obese patients by assuring a minimum tidal volume with lower peak inspiratory pressures. This is an image I took 2 days back when I was ventilating an obese patient for a laparoscopic hernia surgery with the patient in Trendelenburg position. So on the right side, it's a PCV-VG mode, and on the left side, it is a VCV. So the tidal volume set was 500 and the rate was 16. You can see the difference in the peak airway pressures. In the PCV-VG mode, for the same 490 tidal volume, the peak airway pressure is 33 centimeters of water. Whereas the same 490 tidal volume, same rate, same IE ratio, in VCV, the peak airway pressure is higher. So that way, PCV-VG or PCV reduces the airway pressures, but the inspiratory flow rates are higher, and alveolar distension and optimization of oxygenation in the alveoli is improved, because generally in the PCV mode, the flow is a decelerating type of flow rate compared to a constant flow rate in the volume control mode. Achieving adequate ventilation with airway plateau pressures less than or equal to 30 is often challenging in obese surgical patients due to decreased respiratory system compliance along with surgical related factors, which are pneumoperitoneum, sometimes surgical retractors, or Trendelenburg position. It was found by Lewandowski that inflation pressures may be tolerated by obese patients, possibly because the extra intrathoracic adiposity may limit the lung overdistension. So even by giving these high pressures, we are trying to overcome the elasticity of the chest wall more than overdistending the lung. So these patients might tolerate slightly higher pressures than a normal patient.
More fun for you and for Kumara.
It is well accepted that obese subjects are prone to develop atelectasis primarily in dependent lung areas, making recruitment maneuvers and application of PEEP a vital strategy to improve the oxygenation and lung mechanics. Recruitment maneuver plus PEEP compared with PEEP alone added both a statistically significant and a clinically relevant effect on intraoperative oxygenation and increased respiratory system compliance, although it remained unclear how long these benefits were lasting and whether they extended into the postoperative period. Generally, further studies showed that this recruitment maneuver plus PEEP maintained the lung mechanics and oxygenation for 30 to 40 minutes after the maneuver was done. So if the procedure is being prolonged, we might have to do multiple recruitment and PEEP to maintain the oxygenation and a good state of the alveoli to maintain the ventilation parameters. The mechanism by which the combination of recruitment maneuver and PEEP exerts its positive effect could be that the recruitment maneuver opens the collapsed alveoli and PEEP keeps them open, allowing us to have a less driving pressure to ventilate subsequently. During the early postoperative period, and spontaneous breathing, obese surgical patients experience more severe alveolar collapse and impairment of gas exchange than normal weight patients. Therefore, in the postoperative period, a head up or sitting position is preferred. Encouragement of deep breathing exercises, provided pain control is adequate, and mobilization and incentive spirometry is important. Continuous or bilevel positive airway pressure machines can be used to improve the oxygenation and prevent atelectasis in the postoperative time. When postoperative ventilation is needed in obese surgical patients, ventilatory practice in the ICU tends to follow the recommended protective lung ventilation strategies. That is a low tidal volume, high respiratory rate usually titrated to a normocapnia. Obese patients, once they present with respiratory failure in the ICU, usually require longer durations of mechanical ventilations compared to non-obese patients. Overweight and mildly obese patients and otherwise healthy patients may not be at increased risk of ARDS as initially expected. Phenomenon that has been termed, and this phenomenon has been termed as obesity ARDS paradox. So patients with normal weight and severe obesity have increased risk of ARDS, whereas overweight and mildly obese patients have reduced risk of ARDS. The exact cause is not known, but they have found that the inflammatory markers are reduced in this group of patients. Coming to the summary. So this have encapsulated the whole strategy to manage a obese patient. Ventilatory mode PCV-VG may be helpful. Tidal volume 6 to 8 ml per kg, predicted body weight as a reasonable target. Respiratory rate titrated for normocapnia. FiO2 as much as less we have to give to maintain a saturation of more than 90 to 93%. Try to maintain airway pressures near to peak plateau pressures of 30 centimeters of water. PEEP, optimal PEEP is not known, but PEEP is titrated to get the least driving pressure to ventilate the lung alveoli. Combined with recruitment maneuvers, it is more efficient in reducing atelectasis and improving oxygenation. But if we are increasing the PEEP beyond a certain level, 12, 15 and all, then we must be prepared to manage hypertension due to reduced preload. Perioperative adjuvant maneuvers, especially in the postoperative period, head up or reverse Trendelenburg, encourage deep breathing, incentive spirometry, early mobilization, consider CPAP or BiPAP, both in the preoperative, pre-induction time and immediate postoperative period after extubation. Minimize respiratory depressants near to the end of procedure. Consider regional technique, multimodal technique. Prepare for possible difficult airway management even at extubation. In conclusion, obese patients present specific lung physiology and mechanics, characteristics, frequent respiratory comorbidities, and increased risk of postoperative pulmonary complications. Intraoperatively, lung protective ventilation with low tidal volumes, recruitment maneuvers with greater PEEP levels, and the judicious use of oxygen concentrations are recommended. Focused postoperative care seeking to minimize atelectasis is critical. These were my references. Thank you.
Thank you, Dr. Rakesh, for that succinct presentation of ventilatory management in obese patients. You dealt with challenges and strategies, and also you mentioned about obesity ARDS paradox, and concluded with recommendations for intraoperative ventilation. Very nicely done. Now the topic is open for discussion, and I request all the speakers and Dr. Raghavendra to keep the videos on. And to set the ball rolling, may I ask Niskarsh? Niskarsh, you mentioned about waist circumference of 102 centimeters and 88 centimeters for male and females as the cutoff point for the start of problems. These numbers are based on Western figures, or is it applicable to Indians as well?
So these figures are basically for Western population only,
Right.
as per data, but unfortunately our data is very, very limited. So we kind of use them. So I am not aware of Indian data available as of now.
Right.
That.
Thank you for that response. Dr. Madhuri, do you routinely ask for weight reduction for elective surgery when obese patients are coming for surgery procedures?
Yes, so we do ask, provided the surgeon is ready to wait, because most of the times the surgeons only are not ready to wait. But if they wait, then it is a good thing.
Yeah, I agree.
Yeah.
I just was wondering, I don't know whether you can answer me, I have no idea, why the obesity doesn't figure in the RCRI or other risk indices when we assess these patients.
Yes.
Do you have any? I have no clue about that. I just wondered whether it's such an important issue, obesity, it doesn't figure in the risk scoring, especially RCRI.
Yes, I fully agree with you that there are some fallacies with all these risk indices.
Right.
I think obesity could have been included, isn't it, as one of the
Right.
parameters? Yeah.
Dr. Raghavendra, do you want to make any comments or ask any questions?
No, I followed everything, but the problem is they were very extensive. So
No, they have done very well. All the 5 speakers.
So, but I just want to add one thing. The question of whether the Western literature and Indian literature.
Yes.
Indian literature, unfortunately, as Niskarsh said, we don't have it with us. But the problem of central obesity, where the circumference is, beyond 100 and whatever. So that should not, change, because whether it is Indian or Western, the problem is with central obesity, the inflammatory mediators are skyrocketing in them. So they are the ones who develop metabolic syndrome. They are the ones who develop, definitely they will have cardiovascular disease. Definitely they have OSA. Definitely they have all kind of, all these so-called, comorbidities are maximum with them. And I'm sure they have multiple admissions because of breathlessness and, things like that. So I don't think it should be a problem with Western or Indian, as far as the number goes, it definitely, we know that it incites all the metabolic inflammatory mediators.
Right. I agree with you. Thank you for your input regarding this matter. Thank you so much. And Dr. Rangalakshmi was showing a case of 150 kilos. I think it's a very good idea to see whether you can give regional blocks to these patients.
Sir, our experience in this was we have some pain fellows who are quite efficient in this in our department. They have done. But the thing is, though the visibility is good, the onset of action was very, very delayed in this patient. So we had actually given up, and the surgeon was saying that you're not going to be able to anesthetize, and what are we going to do? Because we do not do bariatric surgery regularly. So we shifted the ICU bed and then fumigated because he couldn't fit in even 2 tables. So then, but it acted after half an hour. It took half an hour for the femorosciatic block to act, but it acted. And we did a lean body weight dosing, and it acted. She has had 2 subsequent debridements after that, and now she is in the ward. She has shifted from ICU. She is in the ward.
I really appreciate.
Go home.
I really appreciate how you manage. Did you add adrenaline to the local anesthetic in that case?
Yes, I think.
Okay. Do you have any experience with electrical stimulation of the vagus now to block the vagal impulses from the stomach to the brain so that they eat less?
I wouldn't know, sir. I have not.
I was wondering how to manage if such patients come for surgery. Maybe you have to switch off that electrical stimulator device. I don't know. I'm just loudly thinking. Anybody has any idea about that? Please feel free to express your opinion. This is about vagal nerve stimulation to block the impulses from stomach to the brain so that these people will eat less.
Satiety.
Satiety. But where do you stimulate it? In which part of the vagus do you stimulate it?
I have not seen it. Probably in the neck must be in the neck.
Okay. Okay.
One thing which we have not spoken much is about childhood obesity, sir.
Right.
That is, actually, there are so many, the entire look of childhood obesity has changed, because we used to think that children are plump, they will, reduce, why should we should not do any, we should not interfere.
Right, right.
But any child with a BMI, high BMI, nowadays, they are advocating surgery, bariatric surgery.
Oh.
That is the latest in obesity in children.
I agree. I agree.
If I may talk here, how safe is it to perform a gastric bypass in a child?
They have done it in a 2-year-old in Breach Candy Hospital couple of years ago.
Oh.
2-year-old.
Yes, incredible. Yes.
One of my colleagues, Dr. Hubli, was one of the anesthesiologists. That's how I know.
Okay.
Oh, that's very interesting. Thank you for that input. Are there any questions? Any further questions?
I don't know whether there's anything in the chat box. I didn't find.
Yeah, there's nothing there.
No, sir. As of now, even on our website, we have checked. There have been no questions.
Okay,
right.
okay. Anybody wants to add anything quickly? We can go through that and then finish the meeting.
Sir, if I may add, in our pre-anesthetic clinic,
yes,
we find, as Madam said, a lot of obese children and
yes,
obese, specially abled children also. And they are the risk to anesthetize. We had an obese, specially able child who had to undergo an MRI. So we had to give sedation in the MRI suit for that child. These are the, I feel, the real challenges which we need to, look into. And I think obesity itself is, a lot of it is caused by parents and fast food. So if both of them take care. And
yes. Dr. Raghavendra, do you want to say a last word on this?
Okay. I have some, can anybody enlighten a little bit more about extreme obese patients coming for cesarean section?
Cesarean section, right.
Yes, we have had patients 100 kilos plus who have come for cesarean section. We do not do renal anesthesia because spinal is really risky in such patients. We just give a general anesthesia. I think we have had a few who have come for cesarean section and they have been managed.
How difficult it is to get the spinal?
No, we don't give spinal, sir.
Okay.
Because obesity plus cesarean section, and they are also, we have had 2 or 3, and I don't go routinely to the obstetric theater, but we give general anesthesia. And also these long needles, though we talk about them, they are not freely available in Bangalore. That's another thing which I find. We have tried to get a long spinal needle. This lady also, we used a long sonographic needle to give the block, which was, I think, 12 centimeters.
There's some questions coming up, I think. Can you pass it on quickly? Because we have just overshot the time. Can you quickly?
Yes, sir. Yes, sir. I'm just texting you. It will be better that way. And then you can ask the question.
Yes. What is the role of Sugamedics in reversal of muscle relaxant in obese patients?
A difficult airway when you start, when there is when you're unable to mask ventilate, when difficult airway, it's something which will get you out of the problem.
Right.
16 milligram per kilogram.
Right. Any more questions?
Yes, sir. Yes, sir. Just 2 more. I'm giving all of them together.
Yeah. Role of TIVA. When you go to one lung, you start high PEEP and then go down. What about BP at higher PEEP? Regarding PEEP, Rakesh, would you like to say something?
Yes, sir. One lung ventilation by itself is actually going to cause a lot of incidence of hypoxemia.
Right.
In these patients, it is even more a bigger challenge. So generally, the PEEP which is delivered to the dependent lung has to be a slightly higher value than the usually set PEEP. And ventilation has to be titrated to same 6 to 8 ml tidal volume, and the rate has to be increased to maintain the ventilation. So PEEP is generally set higher than the normal, both lung ventilation PEEP. Compared to that, it's slightly higher.
Right. What is the role of TIVA is another question. Anyone would like to answer it? Because it is anesthetic management, may I request Indrani to say, and then if somebody else wants to answer, they can do that.
As I already said, sir, TIVA has also been tried. Of course, you can give TIVA. No problem about it. Only thing, propofol should be titrated to total body weight when you're giving TIVA for the maintenance.
Right. The next question is about...
and dexmedetomidine, no substitute for that so far.
Right. Can flumazenil and naltrexone consider life-saving measure of other analgesic measures are taken? Flumazenil and naltrexone.
Naloxone.
No, naltrexone is also an opioid antagonist.
Flumazenil is for
diazepam.
Sedation.
No, it is a benzodiazepine antagonist.
Yeah, midazolam. So, actually, midazolam, when you give midazolam,
right,
according to the lean body weight, even if you give according to the lean body weight, it tends to act for a very long time.
Okay.
In morbidly obese patient. So there is a role of flumazenil. Right. There is a role for flumazenil.
Right.
And if you find that the patient is hypoventilating and all that, now we have ultra short acting drugs like fentanyl and remifentanil. I don't think we should be using naloxone. I don't think I've ever heard of anybody using naloxone.
Right. With that, I think we should conclude because our dinners are getting cold. Dinner is being served virtually. So thank you very much for joining us on behalf of Indian College of Anesthesiology. I'm gratefully thankful to Dr. Niskarsh Gupta, who spoke about anesthetic concerns, Dr. Madhuri Kurdi for taking us through the pre-op risk assessment and optimization, Dr. Indrani for anesthetic management, Dr. Rangalakshmi for perioperative complication management, and Dr. Rakesh for perioperative mechanical ventilation. How do you ventilate these patients? All of you have done very well, and I'm really thankful to each one of you for having valuable information. Somebody wants to say something? Dr. Raghavendra, thank you for being with me. And with that,
because my audio, this one was a problem in the beginning.
I see. Not to worry.
Thank
I
you.
really appreciate the contributions of all the speakers and Dr. Raghavendra. And we'll meet again next Wednesday for another webinar. Thank you so much and good night.
Thank you so much.
Thank you, sir.
Good night.
Thank you. Thank you, everybody.
Good night.
Thank you.
Thank you, sir. Thank you.
Thank you.
Thank you.